Now I'm going to speak about Chracot foot and ankle. Can we save the limb? كلكم عارفين طبعا موضوع Chracot foot and ankle. عشان ما يحصلش لخبطة, I'm going to speak about patients who had been indicated for amputation. يعني احنا طبعا Chracot فيه indications كتيرة و lines of treatment كتيرة. I'm going to speak about the patient who was referred for amputation by the orthopedic surgeon, the plastic surgeon, and the vascular surgeon. This is the entity I'm going to speak about. So it's not going to be a general speech. I'm going to speak about this patient who are subjected or prone to limb loss. Like this patient, with a foot ulcer, chronic infected, and the patient with chronically dislocated ankle. First of all, I'm going to give you a questionnaire. So we will see. هاخد رأيكم طبعا. I'm going to take your opinion about this case, a simple case with innocent fracture. 48 years old female with uncontrolled diabetes, type 1, with recent trauma, twisting trauma 3 hours ago, and the skin condition is bad. It's unhealthy skin. It started to be bluish. And this is the picture of the patient. You see just a fissure fracture over there. Just a fissure fracture. What would you think about this patient? Tell me your opinion. حط السلايد يا خالد. You have 4 options. Do you need other investigations? Option 1, are you going to ask for other plain X-ray views? Are you going to ask for CT, coronal sagittal transverse cuts, or CT 3D coronal sagittal transverse? Or you don't need any investigation? I need your opinion now. Can you click your opinion?
نحط يا فندم السؤال الاولاني دوت. حاضر يا فندم. حاضر. نعرض النتيجة يا فندم؟
اعرض النتيجة.
ماشي.
This is the result. Most of you think that you need CT, 3D, coronal, sagittal, and transverse. Most of you, and they will see at the end. Do we need them or not? This is 54%. 23%, they think that we don't need anything else. This is enough. Okay. حط الثاني يا خالد. The second question, which type of treatment you prefer in such a case? Conservative treatment, casting, immediate open reduction, internal fixation, splintage till the soft tissue is better for a few days, then open reduction, internal fixation, or external fixation. Please tell me your opinion. حط لي رأيك في الحالة دي. Okay, حط النتيجة يا خالد. We'll see the result now. More than 50% think that casting is the best. So, most of you think conservative treatment by casting is the best type of treatment. Okay? That's exactly what happened. The surgeon preferred to do casting. And this picture after 3.5 months of conservative treatment. What would you think? Chracot joint. Was it an innocent fracture? ده كان شرخ بسيط ولا كان الموضوع أسوأ من كده بس احنا ما خدناش بالنا. So look to the picture before, just a fissure fracture, and after 3.5 months of conservative treatment in a cast. So what's the story of Chracot neuroarthropathy? It's a systemic disease that generates pathological changes in the musculoskeletal system, causing fractures, dislocations, and deformities involving foot and ankle. What's the etiology? Any condition that causes sensory or autonomic neuropathy can lead to Chracot joint or neuroarthropathy. What's the etiology? The most common cause is diabetes. The most common cause. But also can happen with syphilis. The first reported case was syphilis, chronic alcoholism, leprosy, myelomeningocele, spinal cord injury, syringomyelia, renal dialysis, and congenital insensitivity to pain. The pathophysiology. What's the pathophysiology? We have two theories. The neurotraumatic or neurovascular, or both of them. Most of the people think that both theories work out, the neurotraumatic and the neurovascular. What's the neurotraumatic theory? Minor or unperceived trauma or injury to an insensitive foot. Sometimes the patient does not recognize the trauma in 50% of cases. أو بينكر إن حصل trauma أصلا. So in the neurotraumatic theory, the sensory neuropathy renders the patient unaware of the osseous destruction that occurs with ambulation. This microtrauma leads to progressive destruction and damage to bone and joints. What about the neurovascular trauma? Autonomic neuropathy leading to increased blood flow, which led to mismatch in bone destruction and thensis and bone resolution. Classification. The most prevalent or the widely accepted classification is an old one, 3 stages. The first stage, we have inflammation, fragmentation, dissolution. The second stage, we have coalescence. Third stage is reconstruction. In stage 1, we have marked inflammatory process is present with periarticular fractures and joint subluxation, which occurs at the ends of this stage. Stage 2, inflammatory process, which lessens with an evident radiological deformity. Stage 3, which is a healing stage, foot and the ankle are swollen, deformed, and painless. Stage 0, this is an important stage which was described also. We have localized warmth, redness, and swelling, no visible abnormal radiological findings. Why we don't have radiological findings? Because we have microtrauma. You can see it with plain X-rays. We consider this as a stage 0, and it depends upon the clinical examination. The Chracot neuroarthropathy of the foot and the ankle, we have anatomical classifications. Pattern 1, metatarsophalangeal and interphalangeal joints. It's a forefoot, which has the best results. Pattern 2, the less frank, the tarsometatarsal. Pattern 3, Chopard's, talonavicular, calcaneocuboid, and the navicular cuneiform joints. Type 4, ankle and subtalar joints, the severe type, and also the calcaneum type. Vascularity. Vascularity is very important. The vascularity of the limb is usually preserved and the peripheral pulses may be bounded. This is very important. I don't know why. ليه أنا مش عارف. كتير من الناس معتقدين طالما العيان عنده Chracot joints, Chracot foot and ankle، ده معناه إن في مشكلة في السيركيوليشن. الكلام ده مش صحيح يا جماعة. ومعظمهم بيريفير البيشنت للفاسكولار سيرجن وهم تملي يقولوا للعيان ما تعملش حاجه، ما تتعالجش، لان انت لو عملت حاجه هتحتاج امبيوتيشن لان الدوره الدمويه بتاعتك فيها مشكله. This is not true. Not from my experience, not from the literature. انا مش فاهم الاشاعه دي جت منين الحقيقه. Prevalence. 20 to 40% of people with diabetes are estimated to have neuropathy. طبعا كل العيانين بتوع الشاركوت تقريبا نتيجه ان عندهم peripheral neuropathy في الدايابيتس. up to 13% طبعا في انسنس اقل من كده بيحصل with diabetes. ده اعلى حاجه. ده شكل الشاركوت ارثروباثي اللي بنتكلم عليه زي ما انت شايف هنا. ده شاركوت ارثروباثي of the hind foot and ankle. This is the worst results عادة في الهايند foot and ankle. It's a challenging issue facing orthopedic surgeons. Joint subluxation, dislocation, chronic deformity, bone defect, which may eventually need amputation. The sequels of Charcot neuroarthropathy increase the morbidity and the mortality of the affected patients. العيانين اللي عندهم شاركوت الحقيقه الموربيديتي والمورتاليتي بتاعتهم اعلى من العيانين اللي ما عندهمش. The typical deformity associated with this condition is the rocker bottom foot. rocker bottom بيبقى فيه bony prominence تؤدي إلى حدوث foot ulcer. Then along the instability of the ankle due to which is a major cause of morbidity. بيبقى في عندنا high pressure area على lateral side بيدي حدوث ulcer وinfection. The risk of amputation. في ناس كتيرة كل ما يجي لهم عيان شاركوت الحقيقة they talk about amputation. Many surgeons, when they receive a patient with Charcot joint, they mention the amputation from the start. But there is a higher risk of amputation for some patients. If we have hind foot and the ankle Charcot joint and the presence of osteomyelitis, this is really a risk factor for amputation. In the literature, among the patients less than 65 years old at the end of follow-up, amputation risk relatively to patients with Charcot alone was 7 times higher for patients with ulcer alone and 12 times higher for patients with Charcot and ulcer. Risk فعلا عالي. Limb salvage in this population is especially important, given that 5 years mortality rate in diabetic patients after lower extremity amputation is 39 to 68%. ده يناقض الخرافة. بعض الناس لما بيجي لهم حد عنده شاركوت بيكلموا على الامبيوتيشن، وبعض الناس لما يجوا يعملوا امبيوتيشن يقول لك لا ده لايف سيفنج تو ذا بيشنت. الكلام ده مش صحيح برضه، دي خرافة تانية. العيانين اللي بيعملوا امبيوتيشن المورتاليتي ريت بتاعتهم عالية عن الطبيعي. أنا مش عارف أصل الموضوع جه منين، إن كل ما حد يجي له عيان شاركوت فوت اند انكل يقول له حاجة من الاثنين، ما تخليش حد يلمسك ويحطه في بريس وخلاص ويقول لا ما فيش حاجة، وتلاقي العيان بعد كده انفكتد عنده ألسر وكرونيك اوستومالايتس، أو ينصحه بامبيوتيشن يقول لا 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 اتس لايف سيفنج. الحقيقة الاثنين مش صح، الكلمتين مش صح. Management of Charcot joint depends upon the stage, the site. We know that hind foot and ankle problems are more difficult to treat. The deformities, which type of deformity you have, infection, chronic osteomyelitis, comorbidities, uncontrolled diabetes, and under liver, hepatic, other problems. So all these factors have to be put in mind. Management. Early recognition and intervention is imperative to avoid rapid progression toward permanent foot deformity, ulceration, and the possibility of limb loss. It's okay. Early treatment is okay. معظم الحالات اللي هعرضها لكم neglected cases. Conservative treatment بيتلخص في حاجة واحدة: offloading. Offloading. No more. كل التفكير بتاع الكونسرفاتيف تريتمنت ان انا اشيل الحمل عن الجزء اللي هو حصل فيه تشينجز. ليه؟ البون طبعا osteopenic تماما، فمعرض ان يحصل فيه multiple fractures ويحصل destruction في البون والsoft tissues. So conservative treatment معناه offloading. Offloading, the aim of treatment is to immobilize the affected foot until the inflammation has subsided and the fractures have healed. What's the conservative treatment? عادة total contact cost about 12 weeks. Some people believe in 8 weeks, others 10 weeks or 12 weeks. We prefer 12 weeks. But the problem with this case is that you have edema. You have a swelling. And if you put the cast, sometimes after a few days, it's going to هيبقى واسع على العيان. It's not going to be fitting. So you have to change the cast. So you need frequent changing of the cast. Some people advise changing the cast after a couple of weeks. كل أسبوعين تغير الكاست. But you have to know that casting is not without complications. الجبس برضه ليه complications. What are the complications? Skin irritation in some patients. The second, which is very important, DVT, especially if you have a fat person, diabetic, fat person. You have to know this is a high risk for DVT. So you have to give the patient anticoagulation or to guard against the occurrence or thromboprophylaxis. Alternatively, removable cast walkers and air cast can be used also. Or you can start with a total contact cast, then you change to a cast walker or air walker. We call it air walker. The second problem with casting is compliance and adherence. Not less than 50% or perhaps more. They don't like to follow the rules or they remove the cast or they remove the air walker, they don't like it. So there is poor compliance with conservative treatment. This is well-known fact. In conservative treatment, if you have conservative treatment, we have a failure rate of about 50%. It's a high rate of failure of conservative treatment. Pharmacological therapy. Now we have been treating patients with bisphosphonates, especially in the acute stage. Some people claim that you have good results, but actually from the evidence-based medicine, it's inconclusive results. Surgical treatment. A complete workup and optimization is important to achieve a successful surgical outcome and satisfy the risk to stratify the risk of complication. This is very important. What are the indications for surgical treatment if you have a Chracot joint? What are the indications? The first indication is failure of conservative treatment. In about 50% of cases, we have failure of conservative treatment. Whatever the reason, perhaps it's a non-compliant patient. The second reason, which is very important, the complications. What are the complications or the possible complications? Deformity. Perhaps we have equinovarus deformity, Chracot syndrome of the foot, instability of the ankle. The ankle is unstable. So when the patient starts with bearing, it goes into varus. Infection, ulcer, has a chronic osteomyelitis, recurrent ulceration, ulcer, improved, antibiotics, debridement, recurrence, another recurrence. So the indications for surgical treatment are either failure of surgical treatment or the occurrence of complications. What are the surgical treatment? أنا هكلم بسرعة عليهم. Surgical treatment, realignment and arthrodesis, exostectomies, تشيل الاكسستوز اللي موجود أو amputation. ده اللي مكتوب. Realignment and arthrodesis. You can use internal fixation or external fixation. It depends about the situation. If you don't have infection, the skin conditions, you have put everything. You can use nailing, retrograde nailing or whatever you use, and nailing from the sole of the foot. You can use nailing, you can use plating, you can restore the arch. And you need to do tibial-talar or tibiocalcaneal. This is tibial-talar fusion, tibiocalcaneal fusion. And here you have tibial-talar fusion by external fixation. I'm going to give you an example of these difficult problems, which is difficult to treat by the conventional methods, by internal fixations. We have this child, she's 10 years old with juvenile diabetes. And she had Chracot ankle on both sides. Look, dislocated ankle. Look to the Chracot joints, soft tissue, destruction. She's 10 years old. We used the bloodless technique. It's very difficult to do surgical dissection in such a patient with unhealthy skin. Also with a child with the physis, and they are going to remove the physis. And you are going to remove, such a big area. So we decided to do the bloodless technique. We put the frame on, and we do compression, distraction, 3 cycles of compression, distraction. You see the bone formation. And this is the end picture. No dislocation. It's almost normal. It's not complete union of the left side, but this is exactly stable joint. You see, dislocated joint, again on the other side, the right side. And we did again the bloodless technique, put the frame and compression, distraction, compression. And this is the end picture. This is the left side and this is the right side. Complete consolidation without any incision. And this is the real merit of using external fixation. Because some people, when they want to compare, they compare with simple things. But tell me, can you do this with internal fixation? I don't think so. And this is the real merit of using the bloodless technique. This is 61 years old female, overweight, uncontrolled diabetes. She had Chracot for such a long time. She's bedridden, coming on a wheelchair with totally dislocated ankle, severe destruction, look here, to the talus, the hind foot. And the patient was ready for amputation. Because of the, this was almost consensus that this is not for reconstruction, just for amputation. Because, again, she had recurrent ulcer with infection. Look to the ulcer and infection. So we had infection. So we had dislocation, destruction, superimposed infection. This is the typical patient for amputation. What we did debridement and direct closure of the wound. عادة دلوقتي بنقفل مباشرة بعد الدبرايدمنت. بنقفل غرز وسط. Reduction, reduce the fracture, primary wound closure, frame application, residual equalness. Why residual equalness? Why we left some deformity? Because we don't want to put great tension on the vessels. هتشد الأوعية جامد جدا لو أنت صلحتها 90 درجة. عشان كده احنا سيبنا الايكواينس ده. We reduced the joint, but we left equines. And we put K wires, temporary K wires. Why temporary K wires? Because we want to be sure that the joint is reduced. Under image intensifier, we put temporary wires. And you look, we put the hinges In the middle, at the level of the joint, we put hinges, and we put posterior distractor. So we rotate the foot till we correct the equinus. Now we start gradually correcting the equinus deformity. Then we removed the wire to complete correction of the equinus deformity. We corrected the deformity 1 millimeter per day. Now we have full correction of the deformity for correction. You see here, gradual correction to have 90 degrees foot. So we use acute and gradual treatment in such a case. Remember, in cases with neglected dislocation and severe deformity for such a long time, if you do acute correction 100% لو صلحتها هيبقى فيه great tension على vessels, which may jeopardize the neurovascular bundle. Another case of chronic osteomyelitis. You see this case with this gap, chronic osteomyelitis for such a long time. Again, she was indicated for amputation with soft tissue infection and an ulcer. We did bone scan, we did debridement, compression, distraction, compression. You see complete union, and you see the skin, closure of the skin. Again, debridement and compression, distraction, compression. In such a case, this is not complete union. This is fibrous union, but it is a stable joint. Again, if you have a bone gap, a big gap, you do debridement, big gap and infection, ulcer. Again, it's another indication for, or absolute indication for amputation. We did corticotomy, lengthening, compression, and the bone transport. What are the complications in such cases? How would you manage with this pin track infection? In almost all the cases, you have some sort of pin track infection. How to solve this problem? First of all, we put double the number of wires in case of Chracot. في حالات الشركة بحط ضعف كمية الوايرز اللي بتتحط عادي. ليه؟ عشان لما بيحصل severe infection, we remove the wires. When we remove the wires, we don't have to take the patient to the operating theater. So we put double the number of wires. And we have extra levels of fixations. عشان كده تدخيل العيان لعمليات تانية محدود جدا. كرونيك اوستومالايتس ساعات في الوايرز بقى في رينج سيكوستر، عشان كده لما يحصل سيفير انفكشن في واير واديت انتبيوتيك وما راحش you have to remove it immediately. Fraction of one of the wires، عشان كده حاطين وايرز كتير عشان تغطي الوايرز اللي موجوده. ما الالاينمنت محدود. ستريس تيبيال فراكشن. العانه دي طبعا ما بتسمعش الكلام ابدا. هما non-compliant patients. And she had this fracture. So we thought that this is an ideal patient for amputation. But the patient again refused, as usual. So we put the patient in a cast, and we had complete union of the. You see the union? We didn't imagine that this fracture will unite. We didn't. Recurrence of infection. Another example of 75 years old female. With Chracot joint. And this is after 1 year, dislocated joint, Chracot dislocated joints, chronic ulcer, and infection. All the prerequisites for amputation. Again, we did debridement, compression, distraction, and compression. The problem with this patient that he had to travel because of some problems. So we have to remove the frame early. When we remove the frame, we put multiple K wires, thick K wires, to fix the position and casting for 3 months. Then we removed the wires. You see, complete union and the closure of the skin. Complete union. Again, 57 years old female, diabetic and controlled diabetes, rheumatoid arthritis. She had total knee on both sides. She has the DIXA. She's osteoporotic. She was on treatment for bisphosphonates. She was treated by overreduction, internal fixation, ended up with Chracot joint and severe deformity. You see here, severe deformity. Again, arthrodesis in the frame, and it ended up with union. What about Chracot foot? In this case, was syringomyelia, and we had Chracot foot and osteomyelitis, and this deep ulcer. Again, he was a candidate for amputation. As you know, for cases of osteomyelitis, Chracot joint and spina bifida, amputation is a good decision. We didn't do this. We did transverse bone transport. We did corticotomy of this segment of the tibia. As you see here, corticotomy, multiple drill holes. And we did transverse bone transport. We waited for 10 days. Then we took this segment medially, which increased the blood supply to the area. So we did debridement, as you see. This is 1 week post-operative after debridement. This is just before changing the dressing. And this is the frame. And this is the corticotomy. Some people may say, here is the problem. What are you reworking here? يعني بعضكم هيسأل إذا كانت المشكلة هنا. أنت مالك ومال البروكسيمال تيبيا؟ لا طبعا احنا بنعمل ترانسفيرس بون ترانسبورت. بنفريح سيجمنت حوالي 2 سم هنا و15 سم طولها، وبنسيبها في مكانها بعد مالتيبل دريل هولز، وبعدين بنحركها ترانسفيرس بون ترانسبورت 1 ملم بير داي. ده بيرفع البلاد سبلاي حوالي 300%، بيرفع البلاد سبلاي للليمب كلها، يقوم يكومبات الانفكشن او يحارب الانفكشن السيفير اللي موجود هنا. 1 month after the operation look مع ترانسفيرس بون ترانسبورت، شوف التشينجز اللي عماله تحصل هنا indirect changes. 2 months تقريبا قفل تماما بعد شهرين نتيجه increased blood supply. This is indirect treatment of such a case. This is after 3 months. After removal ده مكان رجعناه تاني مكان الترانسفيرس بون ترانسبورت. Look here, skin مقفول تماما. بعد 2 years follow up، دي الصورة بفور ودي الصورة بعد سنتين. Look to the sole of the foot. دي الصورة بفور ودي الصورة بعد سنتين. This is transverse bone transport. Please don't compare our results to internal fixation. We are doing something else. احنا بنتكلم على عيان مختلف وبنعمل له فكر مختلف. هعمل لكم الاكسرسايز ده بقى بعد المحاضرة دي اشوف التغيير في الفكر. This is plain X-ray وعندنا innocent fracture of the lateral malleus. Patient 52 years old, uncontrolled type 1 diabetes, unhealthy skin. وبص بقى عنده ايه؟ فيشر. فيشر بسيط. اوكي. Do you need another investigation؟ هنعيد السؤال تاني. خالد حط السؤال الاولاني تاني. اوكي. I need your answer now بعد المحاضرة. Do you need other plain X-rays? Do you need CT, coronal sagittal transverse? Do you need 3D, coronal sagittal transverse? Or you don't need any investigation? قول لي النتيجة يا خالد. Yes. Good. Most of the people, they think that we have to do 3D, coronal, sagittal, and transverse. اوكي. السؤال اللي بعده. Which type of treatment you prefer؟ حط السؤال اللي بعده يا خل. Conservative by casting, immediate open reduction internal fixation, splintage for a few days followed by open reduction internal fixation. Number 3. Number 4, external fixation. Please tell me your opinion. حط النتيجة يا خل. Most of the people. ممكن تحط لي النتيجة القديمة بتاعت السؤال؟ You see, the number of people for external fixation was 15%. حط النتيجة الجديدة. Now it's 50%. I'm quite happy with this change. في الحالة دي عملنا زي ما انتم طلبتوا، طلبنا سي تي كورونال، سي تي ساجيتال، سي تي ترانسفيرس، 3D. Look to the transverse. What was the diagnosis? Fracture lateral malleus. Look now, it's not that innocent. We have a fracture of the plafond, multiple fractures. It's not that simple. It's more complicated. With unhealthy skin. Look to the DEXA. لأن عنده osteoporosis كمان. You have all these problems. When you لما تفكر في البلان بتاعتك لازم تحط كل العوامل دي في الاعتبار. Look to the fissures. في الكسور في التيبيا ما هوش مجرد lateral malleolus. Look here. It's more serious than fissure lateral malleolus. What we did? حطينا الفيكسيتور, olive wires opposite each other to reduce the intra-articular fragment, and we fixed K wire for the fibula. See here. And then we removed the calcaneum of 5 أكمام حلقة علشان خاطر نحرك. We want to have early movement of the heel. And this is afterwards with complete union. So we have to think about prophylactic treatment. قبل ما يحصل الشرط. Don't take حالات الفيشرز والتروما البسيطة في الدايابيتس بشكل بسيط، لا. تاخدها بشكل جاد تماما. It's not that simple. So in conclusion, minor trauma to the ankle and the foot in diabetic patients has to be investigated and treated carefully. The application of Elizarov method, low of tension stress, bone transport can be a good alternative for amputation in difficult cases. أنا ما بتكلمش عن الحالات العادية. ما بقارنش عن الريزلتس بتاعت الاكسترنال فيكسيشن والانترنال فيكسيشن زي ما بيحصل في الليترشر. لا لا لا. I'm talking about the patient اللي هو متحضر للامبيوتيشن. This is the real merit of external fixation. Not to compare the external fixation with internal fixation. شكرا يا جماعة.